Have you talked to him? Who will guide him?
सर आप spoken to him, told him that सर मैंने उसे बता दिया सर.
मैम एक्चुअली हाँ वो गाइडलाइन वो सॉरी सॉरी आईपीएस वाली विल गेट दैट. Actually अभी फॉर्मली मैं आपको बता रहा हूँ बेसिकली वो तो कमिटी फाउंडेशन Shall we start this one? Let's go. Start.
Good morning, everyone. My name is Asta, and the topic of my presentation today is examination of cranial nerves. My moderator is Dr. Sumit Mehta, sir. So we have 12 pair of cranial nerves, starting from the olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, spinal accessory, and hypoglossal. The functional types of these nerves are: the pure motor nerves are oculomotor, abducens, trochlear, spinal accessory, and hypoglossal. Pure sensory are olfactory, optic, and vestibulocochlear, and mixed are trigeminal, facial, glossopharyngeal, and vagus. So we'll be starting with our first nerve, that is the olfactory nerve. It is a pure sensory nerve. The primary olfactory cortex is located in the medial temporal lobe, that is the hippocampus, and the function is to carry the sensation of smell from the nasal mucosa to the olfactory bulb. Method of testing: small bottles containing essences of very familiar odor are required. So I'll be testing each cranial nerve one by one. stimulates the olfactory nerve. First of all, I'll ask the patient. First of all, I would like to introduce myself to the patient. So my subject is Dr. Shiva. First of all, I will start by inspecting the nose. I can see the nose is bilaterally symmetrical. There are no visible sinuses or polyps or any scar marks. So now I'll ask the patient to compress one of his nostrils and take a deep breath. And compress another nostril. Now take a deep breath. This shows that the airways are patent. Now I'll ask the patient to close their eyes. Compress and go to smell, you have to smell it and tell me if you can smell it. It's two good smells. Can you smell something? Can you identify the odor? What is this odor? Okay. Now close your other nostril. Now close your eyes. Is the odor the same as the previous odor? What is this odor? Now why is it the same as the two other smells? Close your eyes. Move one of the nostrils. Can you say this? What is the order? Now, close your eyes. Can you identify this order? What is this order? And it's the same procedure with the third order. Can you close your eyes? Compress one of the nostrils. Can you show this? Can you show this? So the patient has been able to identify all the three orders correctly. Interpretation of results. Patient will fall into several categories. First, those who can recognize and name the orders, usually women. Those who can recognize but cannot name, men, can detect a smell and distinguish them but cannot name them. The above results are regarded as normal. Each odor smells same but is distorted or unpleasant. This is known as parosmia. Parosmia is seen in incomplete olfactory recovery following head injuries. It may also occur in depressive or schizophrenic states and in hysterical conversion syndromes. Those who can smell nothing in one or both nostrils or whose sense is reduced on one side as compared to another. This represents true anosmia. Examination of nasal passages is necessary to distinguish neural from local disease. Causes of anosmia: local acute or chronic inflammatory nasal disease, heavy smoking, head injury usually thought due to tearing of olfactory filaments, intracranial tumors compressing the olfactory bulb or tract, atrophy of olfactory bulbs, chronic meningeal inflammation, and Parkinson's disease. Now coming on to the second cranial nerve, that is the optic nerve. Optic nerve is not a true peripheral nerve, but a forward extension of a part of the brain. The visual cortex is located in the occipital lobe. The function is to carry visual impulses from the retina to the optic chiasma and on in the optic tract to the lateral geniculate body, to act as the afferent pathway for the pupillary light reflex by means of fibers traveling to the superior colliculus of midbrain. Now, this is the visual pathway. In the visual pathway, as we can all see,
so we welcome sir, the eminent faculty for guiding us through this German club. Actually, just finished late. So we are on. We just finished practicing.
So this is the visual pathway, as we can all see. This is the temporal field and this is the nasal field. Now, for each eye, from here we have the retinal ganglion cells. So the axons of the retinal ganglion cells, they form the olfactory nerve, and the olfactory nerve goes into the optic chiasma. Now, the optic chiasma is located over the diaphragm cellae, which is a sheet of dura mater overlying the sella turcica, which houses the pituitary gland. So if there is a patient with pituitary tumor and he has some visual field defects, so that would indicate supracellular extension of the tumor. Now, from the optic chiasma, there is decussation of the nasal fibers and going into the optic tract. Each optic tract, it has temporal fibers from each eye and nasal fibers from the contralateral eye. From the optic tract, the nerves, the optic nerve, the fibers, they relate to the lateral geniculate ganglion, and from here the optic radiation starts and it goes on to the visual cortex. Now the method of testing. First of all, we'll test for the visual acuity. In visual acuity, we'll test for distant vision, near vision, and the color vision. For distant vision, we have the Snellen's chart. This first one is the Snellen's chart. And if a person is not able to read English, we have the Hindi chart as well. And for illiterate people, we have E chart, or it is also known as the Kangi chart, in which we ask the patient ki kahan pe khula hai. In the other chart is Landau's ring chart. In this, we also ask the patient where is the opening of this ring. Now, method of testing the visual acuity for distant vision by the Snellen's chart. So what we usually do is we ask the patient to stand at a distance of 6 meters. Now, why at a distance of 6 meters? Because at a distance of 6 meters, the rays are parallel and accommodation is minimized. Now, we'll ask the patient to start reading the alphabets. A, then O, X, B, D, X. And if perfectly the patient has a good vision, a perfect vision, then his vision would be 6 by 6, where the numerator indicates the numerator is the distance from which the person is reading, and the denominator indicates that whether he is able to read the line number 12, line number 8, or line number 9. Now, supposing if a patient is not able to read even the topmost line, that is 6 by 60, then we'll ask the patient to move 1 meter forward. Then it would be like 5 by 60, 4 by 60, and so on. Now, if the patient is not able to read something from a distance of 1 meter, then we'll ask the patient to then we'll do the counting fingers test. In finger counting test, we'll stand at a distance of 6 meters from the patient and then ask him to tell me how many fingers are there. And supposingly, if a patient is not able to tell the counting fingers from a distance of 6 meters, then we'll keep on moving forwards until we come to 1 meter. And if the patient is not even able to tell counting fingers from 1 meter, then we'll ask him, then we'll go for hand movement. We'll ask the patient to cover the hand. Then we'll do hand movements. And even if hand movements are also not visualized by the patient, then we'll go for projection of face. We go for projection of face. ये बताना है लाइट कहाँ से आती है, ठीक है? We'll do this for bilaterally for both the eyes. Now, supposingly, even if projection of rays is also absent, then we go for perception of light. Cover one of your eyes. For near vision, we have the Jaeger's chart. The chart is kept at a distance of 35 centimeters in good illumination and read with each eye separately. The prints are marked from J1 to J7. Then for colored vision, we have the Ishara chart. Now, since the Ishara chart is not so I have got some color papers. I'll ask the patient, the subject, to identify these colors. Can you identify these colors? The patient was able to identify all the colors correctly. Now we come to the visual field. Visual field is a three-dimensional area of a subject's surroundings that can be seen at any one time around an object of fixation. It is like an island of vision surrounded by a sea of darkness. The extent of normal visual field is 50 degrees superiorly, 60 degrees nasally, 70 degrees inferiorly, and 90 degrees temporally. Now, methods of estimating the visual field. To test the visual field, we follow the confrontation method. Now, I will demonstrating the confrontation method. In confrontation method, the patient and the examiner should be sitting face to face, and they should be at the same level. Now, I'll ask the patient, we both move our sticks. Now, I'll ask the patient to cover his diametrically opposite eye. Diametrically opposite, I'll cover my left, cover my right. So now for this eye of the patient, if I divide it into 4 quadrants, this is his temporal, upper temporal, lower nasal, and upper nasal. You have to look into my eye. Okay? You don't have to move your head or move your eye everywhere. centering a moving finger on a moving pen from blind areas to areas of vision, because it is easier to see the appearance of an object rather than to see the disappearance of an object. After the moving finger, okay? So
You have to
this,
stick at a distance of 1
yes, sir, at one arm distance or a distance of 1. So this was the confrontation method. In which quadrant the patient is unable to locate. So if supposingly I am seeing the finger at this distance and the patient is not able to see, considering that my own visual field is fine, then I'll be able to say that. Yes, sir.
But why did you do your own specs?
So because, sir, we have, sir, how would I cover it like this? I would not have been able to cover my eye.
And basically you have to wiggle your finger.
Yes, sir.
Peripherally, and
Yes,
then
sir.
you have to see. Then you have to estimate.
Yes. Now, following this, we have automated perimetry also available. Automated perimeters, they're computer assisted and test visual field by a static method. Commonly used is the Humphrey field analyzer. Now, examining the fundus. To examine the examination of the fundus requires a good ophthalmoscope, a dilated pupil, a still field. In order to overcome the light reflex, diminish the illumination in the room, to overcome the accommodation for near vision, instruct the patient to look at a distant point. Now, since I do not have an ophthalmoscope with me, so how do we examine a fundus? Supposing I am testing for the right eye, I'm testing the right eye of the patient. So I test this right eye with my right eye, holding the ophthalmoscope in the right hand. Similarly, vice versa for the left eye. Now, since we all know the optic disc, it is nasally and the fovea is temporal. Now, the optic disc is at an angle of 15 degrees from the nasal field. So, we hold the ophthalmoscope at approximately at an angle of 15 degrees and look into the patient's eye.
Very easy way is to actually locate your ophthalmoscope to the occiput of the patient. If you will actually try to locate occiput, you go into the back and you'll be able to tease it up. And whenever you using a stethoscope, it's very difficult. You can say with the bookish knowledge and there, always focus on the disc.
Yes, sir.
So if you trace the disc, then you can reach the fovea. You can trace the vessels upward. So for a beginners, if they can see the disc and make it possible to look at the disc, that is it. So just try to focus on the disc.
Yes.
So if the beginners, they can see the disc, focus on disc, that is enough.
Yes, sir.
Then slowly and slowly see the vessels.
Yes,
Those
sir.
who are going upward, downward,
Yes,
basally, between. And then you can pick other findings. Okay.
Yes. So, in the fundus examination, normally this is the picture of a fundus. We have the optic disc, which is nasally, and temporal to this, we have the fovea, which is the central part of the macula lutea, where we have the greatest concentration of cones. Now, from the optic disc, it is also known as physiological nerve head, because from here the optic nerve starts, and from here the central retinal artery and central retinal vein, they also emerge out. So this optic disc, it produces a scotoma because it has no photoreceptors. So in the fundus examination, we look for any exudates, any soft exudates, hard exudates, any hemorrhages, any tapering of veins or crossing of veins over each other. Now the third, fourth, and sixth cranial nerve, the oculomotor nerve. The third nerve arises from the midbrain. It gives innervations to the extraocular muscles, medial rectus, superior rectus, and inferior oblique muscles. It also supplies the levator palpebrae superioris, which when involved leads to ptosis. Autonomic fibers running in relation to this nerve supply the pupillary and ciliary muscles. Now in this diagram, here is the midbrain, and here is the midbrain, and this is the Edinger Westphal nucleus. And from the Edinger Westphal nucleus, the preganglionic fibers they arise, the sympathetic preganglionic fibers, and they move along with the third nerve, to the ciliary ganglion and to the accessory ganglion. From there, the postganglionic fibers arise, and they give innervations to the sphincter pupillae and the ciliary muscles, which are formation and the meiosis. Sir, it's not shown. Now, first of all, the light reflex. The afferent is the optic nerve and the efferent is the oculomotor nerve. Significance. In lesions of the second nerve, direct light reflects on the same side. First of all, I'll demonstrate the light reflex. To demonstrate the light reflex, the prerequisite is the nose should be dim, and then the patient should be looking at a distant point so as to minimize accommodation. Now, for that light reflex, I'll shine the torch from the side of the patient's eye and not in front of the patient's eye, because that will lead to convergence of the ocular axis. So this is the light reflex. When shining the light on the patient's eye, we can see near construction of pupil. Constricted on other side as well. This is the direct light reflex. Now for the consensual light reflex, I'll ask the patient to put a hand on the. Now, if in consensual light reflex, if I shine the torch on one eye, that would lead to the constriction of pupil on the other side as well. So this is the consensual light reflex. Consensual light reflex occurs because there is decussation of fibers at the optic chiasma. Significance. In lesions of the second nerve, direct light reflects on the same side and consensual light reflects on the opposite side is absent due to lesion in the afferent pathway. In lesions of the third nerve, direct light reflex is absent on the affected side, but consensual light reflex is present because of the decussation of fibers. Now the accommodation reflex. The afferent is the optic nerve and the efferent is the oculomotor nerve. Now to demonstrate the accommodation reflex, I'll ask the patient to look at a distant point. So here we can see there is convergence of ocular axis and constriction of pupils when the ocular axis converge. Significance. Accommodation reflex is lost in diphtheria, encephalitis, Parkinson's, and diabetes mellitus. Oculomotor also supplies the levator palpebrae superioris, which, if involved, would lead to ptosis. Now the trochlear and the abducent nerve. The trochlear nerve. The nucleus lies in the midbrain. It has the longest course and supplies the superior oblique muscle. Abducent nerve. The abducent nerve arises from a nucleus located in the mid to lower pons in the floor of the fourth ventricle. It supplies the lateral rectus muscle. Now demonstration of the actions of the extraocular muscle. The prerequisite is abnormal swelling of the line. You just look at the pen. So I move the pen in an H-shaped manner. Starting from the now here I'm examining the lateral rectus of his right eye and the medial rectus of his left eye. Now I'm examining the superior rectus of his right eye and inferior oblique of his left eye. Now I'm examining the inferior rectus of his right eye and the superior oblique of his left eye. Now I'm examining the lateral rectus of the left eye and the medial rectus of the right eye. Now I'm examining the superior rectus of the left eye and the inferior oblique of the right eye. Now I'm examining the inferior rectus of the left eye and the superior oblique of the right eye. So all the actions are fine with the patient. Analysis of diplopia. Diplopia can indicate ocular muscle weakness before it is evident to the examiner. The light rays fail to fall on exactly corresponding parts of two retinae and a false image is found, which is usually paler and less distinct. Analysis of nystagmus. The balance of tone between the opposing ocular muscles is normally so maintained that the eyes at rest remain in the midline. Any disturbance of this balance result in a drift of the eyes in one or the other direction. If this drift is corrected by a quick movement back to its original position and this cycle is repeated frequently, nystagmus results. Now the trigeminal nerve. The trigeminal nerve has two divisions. the sensory root and the motor root. The sensory root takes origin from the nerve cells in the Gazarian ganglion and enters the lateral surface of pons. Fibers for light touch and proprioception terminate in pons, while those for pain and temperature terminate in the bulbospinal root that extends as low as C2 of the spinal cord. Distal to the Gazarian ganglion, nerve divides into three divisions. The motor nucleus is situated in the pons, medial to the sensory nucleus. The motor root leaves this skull via foramen ovale to join the mandibular division. Now in this diagram, as we can all see, this is the trigeminal nerve, and this is the Gazarian or the trigeminal ganglion. From here, the trigeminal nerve can be visualized, and we have three sensory nucleus. That is the mesencephalic nucleus, main sensory nucleus, and the spinal nucleus, and one motor nucleus. Now the fibers for light touch and proprioception, they terminate in the main sensory and the mesencephalic nucleus. But the fibers for the pain and temperature, they terminate in the spinal nucleus. Now, sensory root of the trigeminal nerve, we have three divisions: ophthalmic, maxillary, and mandibular. Now, testing the sensory function. The sensory function is tested in all the three divisions separately, comparing both sides. Pain and light touch are the main modalities examined. Now, I'll demonstrate the sensory part of the trigeminal nerve. We have three divisions of the trigeminal nerve: ophthalmic, maxillary, and mandibular. First of all, the ophthalmic division, it supplies the forehead, the upper eyelid, and the scalp up to the vertex and the mid part of the nose. The maxillary nerve, it supplies the cheek, the part of temples, the upper lip, and the upper palate, and the mandibular division, it supplies this mandibular area and the lower lip. Now, similarly, for the sensory function of the trigeminal nerve. Interpretation. Lesions of the individual divisions distal to the Gazarian ganglion result in sensory loss confined to the cutaneous supply of that division. Lesions at or proximal to the Gazarian ganglion result in ipsilateral sensory loss of the whole face. Lesions within the brainstem and upper cervical cord result in an onion skin distribution of sensory loss. Dissociation of anesthesia over the face, pain and temperature are affected, touch is spared. In lesions affecting the spinal tract and the nucleus of the trigeminal nerve. Now the conjunctival reflex. In unilateral trigeminal nerve lesions resulting in corneal or conjunctival anesthesia, stimulation of these structures fail to produce either the direct or the consensual response, but stimulation of the opposite side elicits both response. Now I'll be demonstrating the conjunctival and the corneal reflex. To demonstrate the conjunctival reflex, I'll take a vasc of cotton and I will for both the eyes. I'll touch the white of the eye, taking care of not to touch the pupil. The touching of the conjunctiva, it results in the blinking of both the eyes. Now I'll test for the corneal reflex. To test the corneal reflex, we have to touch the vasc of cotton at the limbus, not at the pupil. So this has led to blinking of both the eyes. Similarly, we'll do for the other eye.
You have to think it from the side.
Yes, sir. Yes. Now the motor root. The motor root of the trigeminal nerve supplies the muscles of mastication, that is, the temporalis, masseter, the pterygoids, tensor tympani, tensor villi palatini, mylohyoid, and anterior bilious digastric. Now to test the motor function. The motor function is tested by asking the patient to clench his teeth. Normally, the masseters and temporalis on both the sides stand out with equal prominence. If there is paralysis on one side, the muscles on that side do not become prominent. The patient is asked to open the mouth, and normally the jaw is central. If there is paralysis on one side, jaw will be pushed to that side, being pushed by the healthy lateral pterygoid muscle. To demonstrate the motor function, I'll ask the patient to clench his teeth. So here we pubic temporalis and the masseter muscles standing out of prominence. So open the mouth. So here we have the lateral pterygoid muscles and there is no extent and the muscles are standing out of prominence on both the sides.
Second would be here, no?
Yes, sir. So here
Temporalis would be here.
temporalis and
Yes, here.
yes, sir.
Masseter here. Pterygoids here.
Yes. Trigeminal neuralgia. Trigeminal neuralgia is characterized by excruciating pain in the lips, gums, cheek or chin, and rarely in the distribution of ophthalmic division of the fifth nerve. The paroxysms experienced as single jabs or clusters tend to recur frequently both day and night for several weeks at a time. They may occur spontaneously or with movements of affected areas evoked by speaking, chewing, or smiling. An essential feature is that objective signs of sensory loss cannot be demonstrated on examination. Incidence is 4 to 8 per 1 lakh of individuals. Middle-aged and elderly are affected primarily. 60% cases occur in women. Onset is sudden and bounds tend to persist for weeks or months before remitting spontaneously. Treatment, drug therapy with carbamazepine started as a single daily dose of 100 milligrams and increased gradually by 100 milligrams daily in divided doses. If effective, continued for a month and then tapered. Other drugs that can be used are oxcarbazepine, which has less bone marrow toxicity, lamotrigine, phenytoin, or baclofen. Now the facial nerve. The facial nerve nucleus is located in pons bilaterally. The facial nerve has two parts basically. The motor part, which are the branchomotor fibers, so called because it arises from the second brachial arch. The muscles, and it innervates the muscles of the facial expressions, including platysma and the stapedius. The sensory part carries fibers for taste from the anterior two-thirds of the tongue and general somatic afferents for touch, pain, and temperature from the middle ear region. It also gives secretory fibers to the lacrimal gland via the greater superficial petrosal nerve and to the salivary glands to the chorda tympani, which also carries the sensation of taste from the anterior two-thirds of the tongue. Now, testing for motor functions. While talking to the patient, look for symmetry and asymmetry. Now I'll be checking for the motor functions of the facial nerve. Now, first of all, I'll look at the symmetry of the face. The face is symmetrical. Now I'll look for any furrows on his forehead. Now, since right now I cannot see any furrows, so I'll ask the patient to raise his eyebrows. So here we can see one furrow. Here we can see the furrows present on his forehead. We'll also be checking the levels of the eyebrows, which are equal, which are seen on both the sides. Now I'll be looking for orbicularis oculi muscle. I'll ask the patient to close his eyes. So the orbicularis oculi muscle is fine on this patient. Now I'll be seeing the nasal labial folds. If the nasal labial folds cannot be visualized, I'll ask the patient to smile. So we can visualize the nasal labial folds. Now, if the patient has any facial paralysis, then there would be angle of deviation of the angle of the mouth to the opposite side. So here we can see no deviation. Now I'll ask the patient to blow out his teeth. Now I'll do the teeth patient test. Now this is the buccinator muscle. He's able to blow out his teeth. Now I'll I'll go for the platysma muscle. You have to distract him. So the platysma muscle is equal and shifting to other side. So the platysma muscle can be visualized. Not visualized, it can be. Weakness of the stapedius may cause hyperacusis for low tones because it no longer tightens the ossicular chain that protects the inner ear from loud noise. Examination of taste. There are 4 primary tastes: sweet, salt, sour, and bitter. The patient is asked to produce this. I'll demonstrate the examination. Now for the examination of taste, I'll ask the patient to produce out his tongue. And you have to point it out कि आपको कौन सा टेस्ट कौन सा टेस्ट लग रहा है. ठीक है ना? क्लोज हो. Now in between I have asked the patient to wash his mouth, but since we are talking, we have to. Now I do similarly for the second case. So he was able to identify that there is a speech.
So like this.
Yes.
But are you sure that you, when you're tripping, giving in that solution, yes, too?
No, sir, he does not have. Sir, actually, he had to wash his mouth every time.
Oh, even first taste, whether he'll have to actually take it in, because then he'll have to mix it with his palate receptors, and then he might get a clue.
No, sir, he does not have it. How does he know that these things taste?
He actually inserted his tongue again into his mouth, and then he tasted it, and then he pointed it out. Then it will be not with facial nerve. No, facial nerve is only anti-reflex. So you have to actually, with a gauge, you have to actually hold the tongue, let him have that taste and point it out. It might be difficult, but that is the right thing. That is why you have to point it out. You can talk. He tasted it very well. Yes. Point it out. Take it outside and then point.
Yes.
It is that the task go to the part of the time. अभी तो if he अगर हमने टेस्ट ने यहाँ पे एटीरियर टू करके लेटरल बॉर्डर पे डाल दिया और उसको अगर टंग उसने अंदर ले ली तो वही सोल्यूशन पैलेट रिसेप्टर से मिक्स हो जाएगा वहां से सेंसेशन ले लेगी. So tongue cannot be put inserted in, and then since he cannot speak, he'll have to actually point it out. That is what I feel. Sir. This is the right one. Of controversies will have to go ahead.
Otherwise, also we don't have much receptors at the palate level, so taste sensation will come from tongue.
सर वो posterior two third में चले जाएगा तो
नहीं, that is okay कि posterior two third में जाएगा तो कोलोसेक्टल जेल, but जो हमारे taste जो basically receptors हैं, जो exactly, but जो receptors हैं, they are different at the anterior two third and posterior one.
Yes. And
also
also
this usual sensation like sweet, they are at the anterior two third.
उसपे भी एरिया है. Sweet, salt, sour, bitter. So areas में ही डालना है. सबसे bitter is there.
Now testing for the secretory function. The actual amount of tear production may be shown by hanging a strip of filter or the litmus paper from the lower eyelid and measuring the length of moistening on each side. More than 10 mm of moistening is normal. This is the Schimmer's test. The flow of saliva is compared by placing a highly spiced substance on the tongue and asking the patient to raise the tip so that the examiner may witness the submaxillary salivary flow. These tests related to the secretory functions are not often required, and the patient will usually be able to describe any defect spontaneously. Now, Bell's palsy, lower motor neuron type facial palsy. It may result from a lesion anywhere from the cranial nerve 7 nucleus in the pons to the terminal branches in the face on the ipsilateral side. There is flaccid weakness of all the muscles of the facial expression on the inward side, both upper and lower face. It may be idiopathic or it is associated with a viral etiology due to herpes simplex, herpes zoster, or the Epstein-Barr virus. Clinical features. The clinical features are deviation of angle of mouth towards the normal side, absence of nasolabial fold, loss of wrinkles on the forehead, inability to close the affected eye. Attempting to close the eye causes the reflex upturning of the eyeball. This is known as Bell's phenomena. Dribbling of saliva from the angle of mouth, epiphora, that tears flow down from the eye, noise intolerance due to stapedial paralysis, and loss of taste due to involvement of chorda tympani. Treatment: reassurance. Yes, sir. So vestibulocochlear nerve. So the eighth nerve arises at pontomedullary junction. The eighth nerve comprises of two parts. The cochlear nerve carries the impulses of sound from the hair cells of organ of Corti through the spiral ganglion in the cochlea to the cochlear nucleus in the pons. Vestibular nerve is concerned with equilibrium. It is connected with cerebellum and cerebrum. Examination of hearing. Now for the examination of hearing, first we can do the finger friction test, in which I'll ask the patient to compress fingers of one ear. So I'll ask him if he can hear me. This is the finger friction test, or we can do the watch test. I'll bring this has to be done on both the sides. In the watch test, I'll bring the watch from behind towards the front, towards near the patient's ear, and I'll ask him that if he can hear the ticking of the sound. There is another test also, which is known as the speech test. This test is conducted in quiet surroundings. The patient stands with his test ear towards the examiner at a distance of 6 meters. Patient's non-test ear is blocked by intermittent pressure on the tragus, and eyes are shielded to prevent lip reading. The examiner uses numbers or words and asks the patient to repeat it and gradually walks towards the patient. This test lacks standardization in intensity and pitch of the voice, used for testing, and ambient noise for testing place. Now the tuning fork test. We have two tuning fork tests, the release test and the reverse test. Now I will demonstrate for the release test. First I'll explain it to the patient. Now I do similarly for the other ear. So this was the release test. In release test, normally the air conduction is better than the bone conduction. In conductive deafness, bone conduction is better, and in sensory neural deafness, air conduction is better. Now the Weber's test. Normally the sound is heard equally in both the ears. So for Weber's test, and I can keep it at a vertex or at a glabella. He's saying that it is equal for both his ears. Weber's test, it is lateralized to poorer ear in conductive deafness and to better ear in sensory neural deafness. Now, pure tone audiometry. It is a hearing test used to determine the type and degree of hearing loss. It is a subjective test and it is based on as it is based on a patient's responses to pure tone stimuli. Therefore, it is used only in patients and children who are old enough to cooperate. Now, test for vestibular functions. The Romberg's test. The patient is asked to stand with feet together and arms by the side of his eye, arms by his side, with eyes first open and then closed. With the eyes open, the patient can still compensate the imbalance, but with the eyes closed, vestibular system is at more disadvantage. In peripheral vestibular lesions, patient sways to the side of the lesion. In central lesions, patient shows instability. So this is the Romberg's test, in which the patient sways if there is any vestibular abnormality. Now, if the patient can perform this test without sway, a sharpened Romberg test is performed. In this, the patient stands with one heel in front of the toes and arms folded across his chest. An inability to perform this test indicates vestibular impairment. Now, there are some caloric tests as well. The basis of the caloric test is to induce nystagmus by thermal stimulation of the vestibular system. Advantage is that each labyrinth can be tested separately. Patient is asked if the vertigo induced by the caloric test is qualitatively similar to the type experienced by him during the episode of vertigo? If yes, it proves labyrinthine origin of vertigo. Now the 9th and 10th cranial nerve, the glossopharyngeal nerve. It carries motor, sensory, and parasympathetic fibers. The branchial motor fibers supply the stylopharyngeus, visceral motor, parasympathetic stimulation of parotid gland, and controls blood vessels in the carotid body. General sensory, posterior 1/3 of the tongue, tonsils, skin of external ear, tympanic membrane, and pharynx. Visceral sensory, subconscious sensation from carotid body and sinus. Special sensory, carries taste from posterior 1/3 of tongue. The vagus nerve. Motor, it supplies the superior, middle, and inferior constrictors of the pharynx, levator palati, palatoglossus, salpingopharyngeus, palatopharyngeus, and supply to the vocal cords. Visceral motor, parasympathetic stimulation to smooth muscles and glands of pharynx, larynx, and thoracic and abdominal viscera. General sensory, posterior meninges, skin at the back of ear, external tympanic membrane, larynx and pharynx. Visceral sensory from larynx, trachea, esophagus, thoracic, and abdominal viscera, stretch and chemoreceptors. Purpose of the test. The 9th and 10th cranial nerves are tested together for elevation of to test the elevation of palate and contraction of pharynx, to examine the vocal cords, and to determine the integrity of the gag reflex. Now to test for the 9th and 10th nerve, notice the pitch and quality of voice, cough, difficulty in so I'll demonstrate it. So first of all, we can since it's a the constrictors of pharynx, so I can ask the patient, आपको खाना निकालने में कोई दिक्कत नहीं है? For to test the muscles of the pharynx, आपको बोलने में कोई दिक्कत होती है? So we have no difficulty following a solution. Now to test the muscles of the soft palate, I can ask the patient to say words like egg. So when he says words like egg or rum, then the muscles of the soft palate move upwards. So if he's able to say these words, then his muscles are firm. So his muscles are firm. So now I'll demonstrate the gag reflex. To demonstrate the gag reflex, I'll be using a tongue depressor. So I'll either touch the posterior part of his tongue or the tonsils or the posterior pharynx. So gag reflex is characterized by constriction of the muscles of pharynx.
If you can depress the tongue, and then you can ask the patient to say something, and you can see if it is symmetrically coming down.
That is also observe also. Because you realize
The accessory nerve. It is the spinal root of the 11th nerve that is being examined here. The cranial root joining the vagus after leaving the brainstem supplies the pharynx and the larynx. Function is it supplies motor power to sternocleidomastoid and the trapezius muscle. The purpose of the test, to detect wasting, weakness of these muscles. So first for the sternocleidomastoid, first of all, I'll inspect for both the sternocleidomastoid. So this is the sternocleidomastoid. Both the sternocleidomastoids, I can visualize no wasting can be visualized here. Now I'll ask the patient, और मैं इधर इस साइड प्रेशर डालूंगी, तो you have to resist the movement, okay? So his sternocleidomastoid can be visualized for this side. Now similarly for the other side, similarly for the trapezius muscle, I'll stand behind the patient, and first of all you have to inspect the trapezius muscle, and I'll ask the patient to raise his shoulders. Now he is able to move his shoulders. Now what I do is मैं pressure डालूंगी, आपको resist करना है. So the patient is normally able to resist the maneuver. Now the hypoglossal nerve. The 12th nerve contains only motor fibers. It supplies all the intrinsic, longitudinal, transverse, and vertical muscles and extrinsic hyoglossus, styloglossus, genioglossus, and geniohyoid muscles of the tongue except palatoglossus. Function, it controls all the movements of the tongue and certain movements of the hyoid bone and larynx during and after deglutition. Purpose of the test, to inspect the surface of the tongue, to detect wasting, weakness, and involuntary movements, to examine voluntary muscle control. Method of testing. the midline, there is no deviation of the tongue C. Now I ask the patient after the tongue C and external. On the pressure balance is happening. So the power of the tongue is also correct. My references are Bickerstaff's Neurological Examination in Clinical Practice, Hutchinson's and Harrison's Principles of Internal Medicine. Thank you.
I have a lot to say that it's a very good presentation. So, sir, this now cranial nerve, very big topic. Yeah, I haven't interrupted her in between. It's very difficult to cover. I have it's better if we go, the nerves which are controlling the eyes, right? Optic and oculomotor, we can discuss. Then fifth, we can be discussed separately. There's a very big nerve supplies both sensory nerves and then motor nerves. Okay, and then we can discuss this ninth and 10th, 11th, 12th separately. So I think instead of one class, so that we can focus on few clinical points. We have to cover 12 nerves at a stretch. It's very difficult. You have given a very good attempt. I think even our PGs will not be able to present that well. It's up to your personal efforts, and we all are learning. But it's very difficult, sir. So if we can, anyway, you get the time, it will be like this facial nerve, which is important for us, and optic and oculomotor. These three nerves are very important as well as clinical examinations are concerned to pick the findings. And these are three nerves which confuse both psychiatrists as well as physicians, neurologists. So if we can discuss these three nerves separately or in one go.
So we'll plan it. So
yeah, we can get some time somewhere. So one day we can discuss optic and oculomotor so that we can have some discussion. And then we can discuss facial also, because it's also confusing. So these three nerves are very important for us. But you have done very well. I think it's a good attempt.
Thank you. I was supposed to be tired and thank you guys also. I think we have helped in the time which we have one or two queries or additions.
I think job was made very easy by Dr. Shiva. See, imagine doing the same thing with patients who have psychiatric disorders. Where the real challenge would come. That is why all these things need to be practiced. Patients are admitted. So they have their own variations, own clinical findings. There is something which will not be able to elicit. It has to come in your procedural name. So these things have to be done routine basis in patients who are admitted here and in outpatients, how much ever it is possible. And then basically how to do it. And then eliciting, we can always take help of colleagues and faculty members from medicine in deciding. And becomes very important because many psychogenic presentations unnecessarily are sent for a lot of investigation that ultimately turn out to be functional. And I remember one of the similar presentations, I think Sumit had only pointed out that we also need that how a nerve is important in the context of psychiatry. In the sense that psychogenic presentations, how they present, so it will make it even more fruitful and clinically more important. But very well presented. Very
See, whenever we find, you see a patient and they're finding, suppose it may be psychiatric patient without opening his eyes, they just close it. So there we should be, able to pick whether this is functional or this is organic. That is basically the motto of examination. So before we label this is functional, we should always be careful that it may be organic. Okay, so if we miss the organic, that would be a blunder. So our focus is to have some, make some points, clinical points, which from where we can just pick easily whether this is just functional or this is the organic. And except for some young patients who have coming to you, patient is young, you can just make it whether this is theory or condition disorder. She may be doing any sort of movement. But I'll advise that if patients are elderly and they have underlying risk like diabetes, hypertension, organic should be at that top post. and there is no harm in going for, if you are not able to pick the findings, not able to make it clear whether this oculomotor this is this suppose the there is total ocular PGR is external or internal. There are some findings you are not able to pick. There is no harm in going for taking the help from ophthalmologist or going for MRI or CT, because these investigations are easily available. So sometimes we pick findings, subtle findings we are not able to pick, and there is no harm in going for investigation. Then that is sorry figure at the
Generally, what happens also said that when we are not able to comprehend the situation, we say that it is psychiatric.
Yes.
So it is very, very important that
it's
it has
very
to be
important.
ruled
We should not miss the opportunity,
out.
because once you miss, it gives because the in neurology time is also very important. So if you miss, time is lost, and then you don't have much option for that.
There are no queries. Thank you. You can finish your comments.
I think very well presented and commented.
Very great. What I saw was very good. I feel itself that we should not have a knee-jerk reaction to whenever we find any problem. We need to refer to neurology, refer to medicine. We need to do it ourselves, find out, and screen patients, because we only refer patients who report something. Sometimes the problem may be there. The patient maybe have some genuine problem. So we need to know how to do this examination. Secondly, yes, always keep organic disorders as the first high index of suspicion.
Also, when the patient is coming, has come in to us in the past with functional issues.
Yes.
Second time patient comes, we consider it's a functional.
Right. We need to do
Again, we need to be very
careful.
careful.
Examination every time. So
Still remembers a very interesting case. The patient came to us with aesthesia this year, admitted here. Second time patient came, we considered it is an aesthesia this year. Finally, we found actually patient had fracture at a fall. That real fracture, because of which second time patient was not able to walk. So it was very late subsequently.
we need to do examination every time.
Yes.
And consider fresh complaints also in a patient whom patient associated with fresh complaints. We need to assess this complaint and fresh complaint before just considering that associated.
I think very good. And I told you we can discuss these terms in a separate class, like I, Vegas, this 9th and 10th, and patient. We are all, I think we all are learning, and especially if we see this cranial nerves, it's about 1/4 of the quantum of neurology. So
Yes.
those who are neurologists, it carries 1/4 quarter. So it's a quarter of the neurology. So it's not easy to cover in one class with presentation. Very good.
Yes, thank you. Great topic. But in psychiatry, we must learn to finish this little part also. About start with, but when you take your case in examination, you will evaluate that, and you cannot say to the learner that you did do it. So in history also you must evaluate something, and while taking history you can do a little bit of testing also if you have time. And then in the last you must know what important nerves you should not miss. You must just didn't have this testing. I understand it becomes very difficult. There's a lot of management and other things you're supposed to know before taking it.
But please don't write you have examined and you have not examined. Whatever you put in examine, say I put like that. Otherwise, a problem. So we'd like to actually felicitate our guest, sir.
I think I have taken the lead more than
Dr. Dhyani said to please hand over memento and the certificate to sir.
we have to agree on that.
Yes, sir. It will be disturbing. Sir, take your pleasure, sir. I'll take the permission.
थैंक यू। सुना आपने? कंप्यूटर को बंद कर